this is David Spiro. I'm a professor of pediatrics and pediatric emergency medicine physician at UAMS and Arkansas Children's, and I am incredibly delighted to be your host here on Hume Human Medicine, where we explore stories and how physicians and folks in healthcare work behind the scenes to do the crazy things that we do, and have some sort of learning piece around this that may not just be cerebral, but also from the heart. And I am incredibly delighted and honored to have an old friend and colleague, Dr. Peter Antevy, with us today. And Peter, would love to have you introduce yourself in terms of how you got here today, your training and your background, and what you're doing now in the world.
Awesome. David, thank you so much for having me. I love your podcast. I love the concepts behind it, and thanks for the invite. For your audience, so my name is Peter Antevy. I am trained as a pediatric ER doc, just like David. Started in Los Angeles for my residency, Pittsburgh for my fellowship, and then found myself back down here in South Florida since 2005. Working at a large children's hospital, tertiary care facility, level 1 trauma center. And then my life changed quite dramatically in 2010 when I became an EMS medical director. And just for those people who are not familiar with that, it became a subspecialty in the House of Medicine to become a medical director for a fire department. Obviously I say fire department, but to manage, the paramedics and the EMTs, there's now a subspecialty. It's another board certification. So I got that. And now I have transitioned out of the emergency department into running pretty large fire departments where we cover about 2.5 million people. I work with about 3,000 paramedics, and it's really, really the best job in the world. And then, as part of the story I'll tell in a minute, I also started a software company that helps paramedics, nurses, and doctors get the right dose at the time where the child is seizing, having a cardiac arrest. We actually present them with all the cognitive information that they would need to treat that child when seconds and minutes count. And so that's something that is something that I'm really passionate about as well.
Yeah, and Peter's being humble, but he started a company that's now prolific, and we used to use tapes to measure children and figure out weights, which is a bit awkward. And Peter is a leader in the way we think about errors and giving children the right dose, because children who are small usually need less of a dose than children who are bigger. And Peter's worked from his clinical observations at the bedside into taking some awesome ideas and bringing it to the world. So we're incredibly honored and to have you here, and thank you for that introduction. And with that, we'd love to hear your story and explore it.
Yeah, thanks, David. My story goes into a significant medication error that I made very early in my career after I came to Florida. And the story I'll tell you is not the first medication error I made, but it's the worst one that I made. And for many years, I never told anybody about it. I was ashamed of myself. I felt embarrassed to even tell anyone that, I could have made that mistake, because I love being at the head of the bed. I love being in the resuscitation. I love leading the team. And when this story that I'm about to tell happened, everything flipped on me, because I recognized at that point in time that I was in big trouble, meaning that if God forbid I was ever in that situation again, would I be able to manage the situation better? And the interesting part about this story, David, is that it's not an error of commission, meaning I didn't give the inappropriate dose, which is my other errors. In this particular case, I just didn't give the dose. I didn't give the drug. because I didn't know how to get to it. Didn't know how to know. I didn't know the dose. I didn't know how to mix it. Didn't know how to set the pump, etc. And part of what I've learned is that most of the errors that are made are errors of omission. So I guess I'll go right into the story, which is, you know, starting in 2005, I I became the ER attending in the pediatric ER, meaning that after the training, you're it. You're in charge, right? There's no one that you have to go and present that case to. It's you who are making the final decision. Um, and you know, early on in your career, you're still kind of getting your sea legs about you, etc. But this was a particular case where um, a girl comes in. She's around 7 years old or so. This is many years ago. She's 7 years old, and she was clearly septic. She had a very bad infection. She had been seen by other doctors. And so by the time she came to me, she had she was tachycardic, high heart rate. She was hypotensive, low blood pressure. And you could just tell by her skin color. You could tell by how she was breathing, how she was looking. The parents were very anxious. And I knew obviously that this girl belonged in our resuscitation bay, right? That was clear to me that we had to start working right away, and we did, right? We have nurses who, you know, place two IVs in, start giving IV fluids, checking some labs, getting antibiotics, and so forth.
And Peter,
And
before you continue the story, just real quickly, we have a lot of folks here who are listening who are early learners. You did something in that moment, which is a very important part of what we do, and part of our training in pediatric emergency medicine is recognizing the sick child. Now, you could argue that any child that comes to the emergency department is sick, but can you describe to maybe our early learners what we mean by that when you say recognizing sick? Because you recognize this child and you brought her into the resuscitation room, which is the area where we bring the really sick kids. But what about this child made you feel like she was sick that we needed to do something right away around?
yeah, that's a great question, and it does deserve a lot of explanation because in our specialty, it's really the assessment is really a very key part of the outcome. It's a key aspect of the care you deliver, and it's a key aspect of how the team around you performs, right? Are they going to prioritize what you're about to tell them, or are they going to deprioritize it, saying, that sounds like something I can do in 30 minutes from now? And what I've coined the term is a blink assessment because trying to teach people that these types of assessments are done from across the room. And especially with children, when you're a stranger and you're coming and you're standing tall and they're, let's say, laying on a stretcher, and you walk right up to them, and I'm 6'1", and all of a sudden I'm leaning over somebody. All of a sudden you don't really get the true assessment of what's really going on. So I was always of the notion of, walking slowly, talking slowly, speaking very clear, simple language, making eye contact with the family first, getting to understand what could be happening there, whether there could be, anxiety, fear, nervousness. Obviously, you're getting the story at the same time. You're evaluating what the relationship could be with the child. Is it a positive one, a negative one? And then starting to focus on the child themselves. And once you start to recognize that all the pieces fall into place, worried family, this is their child. They did all the right things before they got to me, and now they're sitting in front of me. Now I turn towards the child again. I'm not right on top of them, and I'm doing really like an ABC type of evaluation, and you can do all those things from across the room as far as in this case being appearance, right? How do they appear to you? What's their look? Do they have a furrow in their brow? Are they even looking at you? What's the color of their skin? Are they diaphoretic? Are they sweating? Um, are they pale? Are they flushed? There's so many things you can get just by looking at somebody that your brain is um, detecting those things without the spoken word, right? And as you refine that skill, um, let's say you're a medical student, then you become a resident, then you become a fellow, then you become an attending, then you work for many years. You, if you're in the field of working with sick children, and every shift you're seeing, let's say 35 to 40 kids, you can do the math that over time you could walk into a room and the appearance becomes something that's um, um, I want to say it's repetitive, but it's something that it'll lock in as soon as you see that sick kid. And the experienced clinician will have an easier time of determining which kid is really sick versus which is not. Because oftentimes, as you know, David, when you walk into the room and it's 2 o'clock in the morning and the kid's got a 103 temperature, but so do all the other kids in that same row. And they all are sick. They're all crying. They're all tachycardic, and they all have a 104 temperature because it's, cold and flu season. How do you differentiate between the one of the 10 that's really sick? And a lot of times it's by understanding the nuance in that appearance. The next thing is breathing. How are they breathing? What's their effort of breathing? Um, are they struggling? And you can look from the face down to the chest into the abdomen. And again, you're across the room. You haven't even touched the kid. There's no monitors on yet. You haven't put your stethoscope on the kid's chest yet. This is all just across the room. And the same thing for circulation, which is the C, which is the heart pumping enough blood and therefore oxygen to the parts of the brain? Meaning, are they alert enough? Are they getting enough oxygen to the brain to actually look up and talk to you? And on your last podcast, and the patient that you described, it was a child who couldn't even look up at you, right? Because it was having an issue with the brain and perfusion. So those are kind of like the key things that um, we do in the pediatric ER that are unspoken. They're visual, and it's very nuanced. So I'll throw it back to you. Is that good?
No, that's great. So tell us again about the story. So, and I'm sorry I interrupted. So you came into this room and recognized this child was sick.
This child was sick, and based on the couple of historical points that I received, which is that she has some sort of infection. She's been sick for a couple of days now, and looked like she was getting better, but then suddenly got much sicker, which is always a concern, right? Usually the kids get worse by day 3 and 4, and then we tell the parents that you kind of we can kind of see the light and it'll start to get better now. This kid got worse, started getting better, and then got sick again and got really sick again to the point where they brought her back into the emergency department. And by the time I came in to see her, her appearance, her breathing, her circulation were all off, meaning that they were not normal. And it was kind of easy to tell that to be the case. Easy enough that when we brought her into the room, we didn't bring her to one of the regular rooms and then move her into the recess bay. She was brought right to the recess bay upon arrival. So she was one of those kids where you could detect that she was very sick. In this case, I use the word sepsis, or an inflammatory response caused by an infection leading to the body starting to not be able to catch up. And the body now is in a decompensated state. And for those of you who are listening, when you have an infection that leads to sepsis, the mortality rate in adults and children could be up to 40%. And all it takes is for you to do is to Google sepsis, and you'll see that a lot of people die every year. Many more than die from heart attacks, many more that die from cardiac arrest. It's basically sepsis is a huge killer in America today, and it's oftentimes leads to death because of the untimely treatment of that disease. And so here I am. If you can imagine, I have about 3 to 4 nurses around. The parents, of course, are in the room. I always keep the parents in the room as I'm talking to them, as I'm doing my kind of more formal assessment. now next to her, having a set of vital signs and starting to develop the plan of treatment, the course of action, and that we do pretty rapidly, right?
Mm.
Uh, she wasn't kind of fully there with us, if you will. She was arousable, but you could tell that she was kind of wifting off. Why? Because her brain wasn't getting the enough oxygen and enough blood supply because her blood pressure was low. The infection was kind of taking over in this particular case. Um, so it's pretty protocolized, I would say, everywhere that you would go, where once you recognize sepsis, hopefully it's not too late, but the later you are in the presentation, the faster you have to work, the more you have to do, the more critical things get. We knew that she needed to work quickly, so the first thing we did, put oxygen on her, and then we go ahead and we obviously had all the monitors on her, but we put two IVs, one in each arm, and we started infusing IV fluids to try and bump up that blood pressure because this particular infection and like others, it was really dilating her blood vessels. It was causing leakage of the blood of the fluid through the blood vessels, and therefore her blood pressure was dropping. And infection obviously needs antibiotics, so we gave her two different antibiotics. And all along at this point in time, David, just so you know, I'm feeling comfortable with what she has. I'm feeling comfortable with what we're doing, and I'm going through the steps of what any of us would do at the bedside when we're presented with a tachycardic, hypotensive child who's in septic shock. Obviously, the labs are being drawn, and um, the next thing that has to happen in this particular case is you keep giving more fluids, and you're trying to make a determination. Does the child need something more than just IV fluids? And in particular, do they need a vasopressor, something like norepinephrine or epinephrine, that type of thing? And for those people who deal with children in a pediatric emergency department, it's truly not often that you're starting pressors on children. It's not like an everyday thing that you do. When you deal with adult medicine, and now that I deal in EMS, oh, we do it all the time. Remember, I'm early in my career. I have a kid who I'm going through my progression, and then finally I say to myself, this girl needs norepinephrine. I'm convinced. She already had two boluses. I'm giving her a third. I'm not seeing any bump in her response to her blood pressure. Her heart rate is still elevated. She's still not looking right. And now is the point in time where here I am at the head of the bed. Parents are next to me. Nurses are all in the room. And David, I'm sure you've been here where you ask a question, meaning I need this, can someone get me this? And almost every time, I'll say in the high 90s, as a physician leading the resuscitation, you're going to get a question back at you. So I said, can we get a norepinephrine drip? Right? Now, I did not want to ask that question for, the prior 15 minutes. Why? Mom and dad are right here next to me. And I know what's going to come from the nurse right when I say that. They're going to say, oh, doctor, what dose would you like to start that at? How should we mix that? What do you like me to start that infusion pump at? And I didn't know any of those things. Okay, now you may ask me. I've been doing this for uh, over 20 years. It's not going to be a problem because of now what I do today in the company. But so I didn't know the answer to that question, and the nurses didn't either. So here I am. The parents are now thinking, okay, what just happened there? This guy asked for something, didn't know what I was asking for.
Mm.
And between me and you, I said it very quietly so that I was hoping the parents didn't really hear me, and I don't think they did. I had nurses giving me blank stares. Happened to be a nurse outside the code room who's been doing this for a long, long time, who's a good friend of mine. So I kind of slither out of the room real quick, and the parents were wondering where I went. And I said to the nurse, I need a norepinephrine drip now. And she
Yeah.
says to me, "What dose?" And I said, "Here we go." I said, "Do me a favor, just call pharmacy and please help them figure it out." She's 7 years old. She goes off to the phone and calls Steve from pharmacy. Okay. She gets Steve on the phone. What dose does he want? So here we go all over again. It's like, so finally 20 minutes goes by and she comes back into the room and she says, "Steve's getting it ready." I said, "Great, Steve's getting it ready." I'm looking at this girl now. Do I intubate her? Her pressures are too low. The ICU had already been called. Okay, ICU's been called. I go up, waiting for the med, not coming yet. I get a call. The ICU's ready for her. I'm like, thank God, ICU's ready for her. We take the monitor, put it on the bed. We start to package her up. I tell the parents, okay, the ICU's ready for her. Here's what to expect when we get up there. It's on the 4th floor. We we package her up. We start walking up. All along, I'm looking at her vital signs and I'm thinking, not good. She's hanging in there, but I knew all along that her blood pressure was not normal. So what do? We go upstairs to the 4th floor. Um, the double doors of the ICU open. The parents are with me, and the ICU is literally waiting for me. We walk through, and the ICU doctor, who's not a nice guy, never been a nice guy, he looks at me, he looks at the monitor, and he says, "What pressure have you started?" And I said, "Gerald," I said, we haven't started it yet. And right then my phone rang. "Who is it?" "It's Steve." "Where's Steve?" "He's in the emergency department." And I said, "Gerald, it's in the ER." He looks at me and he says, "Pete, get out of here."
Mm.
Parents are right there looking at me.
Mm.
So you can understand now that they know something's gravely wrong.
Mm.
He did that right in front of them. Okay. And now I turn around dejected and walk away, praying to God that this is going to be okay. So,
So,
I keep
so I
trying.
want to get to that. I want to get to that moment. You walked away after being um, put down by this ICU physician, and this is not the first time I've heard these kind of stories. And it may not be ICU ER, it may be surgery, or it may be
Mm,
because we work with all the specialties in emergency medicine. Is the we work with all specialties. So as you're walking through the door, as you're leaving, and felt, you had shared that you felt like you didn't know the dose, and then there was a delay, and then it was, it was sort of put out there in front of everyone to see.
mm.
What kind of emotions were you feeling in that moment?
I mean, I felt like crap. I felt stupid. I felt incompetent. I felt like I let not just the family down, but I let the patient down. I let my team down. And as you know, when you work in a high stress environment, when
Yeah.
people come to work with you and they see who the doctor is that day, they make their assessment of whether today's going to be a good day or not. And they base that on prior experience. So what nurse wants to work with a physician that couldn't get it right, that didn't do the right thing for the family, for the patient? And so you automatically think to yourself that um, these are people who I need to gain their trust, not just for today or tomorrow, but for potentially 20 years of a career, right? And um, all those emotions went through my head at that same time because I was relatively new to this place. And like I had mentioned before, there were two other errors which we haven't talked about today. We won't talk about today, but they were not as bad. But I had started to develop this reputation there of he's a nice guy, but maybe not the guy for the code room, right?
Mm.
And and I understood that it wasn't because um, that it wasn't because I didn't feel confident in my knowledge. It's because at this particular hospital, I wasn't in residency or fellowship anymore, where when you say I need a NorEpi drip in Pittsburgh, it shows up. When you say it in LA Children's, it shows up. So how things happened at these other kind of, let's call them the ivory towers, very different than what happened in the rest of the world in what I call the Saint Elsewhere Hospital, where the expectations are different there. And I just wasn't ready for that. But I didn't know that I wasn't ready for that because I just thought that I would ask for something and it would be there. But in more than one case, it wasn't there.
So I want to also name something else. You named it, and it's not what we talked about, but I would like to spend a few minutes talking about it. And I always say that the most important part of medicine is bidirectional communication. And whether you're talking with a family, it's good listening and good speaking skills, and also with colleagues. There are lots of words to say what happened in terms of how the ICU physician handled it, but one word that just comes up is unprofessional. That is, if you have a colleague who's struggling or may have not made the right decision, the strategy is not to admonish and put down, and because folks don't learn well that way, and it never turns out to have a good outcome. I mean, what we should all be doing together is we're all partners, and the idea is that this child is under your care and is under the ICU doctor's care, and the goal is that we're all caring for this child. And if the ICU doctor really knew what was going on, much of what happened was out of your control. Steve showed up in the ED and you were moving, and if 5 minutes later you had not brought the child up, maybe the child would have showed up with a pressor and it all would have happened. But it's very important to call it out. And we are in 2025. It is very important when someone is unprofessional to name it and then ultimately talk about it off the clinical floor. So there's a learning opportunity, because we work in a high stress environment. This child was massively ill. I'm just curious, when you're supervising thousands and thousands and thousands of paramedics, and you're a mentor now and a mentor of mentors. So what is your approach when two paramedics are working together and there's unprofessional behavior? What is the best approach if you're a young learner when that happens?
David, that's a great question, and what's happened to me in my career has definitely impacted how I move forward. I will say before I answer that what I've recognized, fortunately or unfortunately, is that in our profession, specifically on taking physicians, you see this type of behavior more frequently than not. And I never understood it. It is unprofessional. It's not collegial. And I'm not sure if it's because in medicine, it's really a solo sport for a lot of people, if you will. It's not a team game. And throughout, medical school and residency and fellowship, there aren't those team dynamics that it's not a muscle that you have to flex. You have built a great company. I'm building a company, and you realize it's all about the team. And what I love about EMS, to answer your question, is it's one huge team game, and we are very collegial. We are very professional, and we try to utilize what we call just culture. And so instead of just admonishing, you go and you're instead of being very punitive towards somebody, you really evaluate everything that happened. And because it happens all the time in EMS, where I get a phone call, it happened the other day, and someone said to me, your medics did this. So your first inclination, if you don't really understand how to go through the process, is to say, well, I'm going to call them and let them know what they did wrong. That's the wrong thing to do, right? that you really have to go through the process to say, as you mentioned earlier, it's bi-directional. I ask a lot of questions. Okay, tell me more. Be more specific. Do you have the time? Do you have the date? Who was involved? Do you know the names of the crew? Um, do you have the record? If it was a concern about a dose or not a dose, I would say, well, how are you sure that that specific dose was given?
Yeah.
One time I had someone said that they gave a very high dose of ketamine. Oh, how are you sure about that? So you start to ask the questions, and then you go to the next step, which is now you go and evaluate what you can do on the EMS side. You say, okay, let me look at the run report. Let me talk to the EMS captain. If it gets to the level where, okay, something did happen here, then we actually meet face to face. And I actually give them a chance to tell me everything. And in fact, I actually have them write down before coming into the meeting everything that they remember from this call, right? Because you remember, oftentimes by the time these things bubble up in EMS, sometimes it's weeks later, right? Where you get a complaint from somebody and you have to go and evaluate. And now it's been a few weeks and that person really has to remember exactly what happened. And oftentimes their version of what happened is very different than the version of the other person. Very different. And you then have to really bring that all together and say, what do I think really happened here? And then make that determination. So coming to that conclusion, like in my case, of what exactly happened, it really wasn't Gerald's problem or wasn't this doctor's problem, but it was the problem, but it was a problem. There was a root cause here. Okay. And at the hospital, as you know, they do these things called RCAs, or root cause analysis. That's what should have been done here. And that's what should be done in many of the errors that happen in hospitals. But unfortunately, it's not what's done. They just say, oh, that physician needs to do better next time.
Yeah.
That paramedic has to do better next time. Instead of saying, is there a systems problem here that didn't allow that medication to be known? To someone should know the dose right off the bat without having any questions asked. Perhaps we should have been able to mix that medication in the emergency department ourselves, which we do today, obviously. It seems obvious now, right? Um, and the speed to which that medication should have come on board should literally have been maybe within minutes rather than what ended up being, I think, 45 minutes to an hour, by which time I was already up in the ICU with the patient.
Yeah. Well, it's a fantastic story. And first of all, every time someone tells a story, I get to know them better and in a much deeper way. And I've known you for at least over a decade, and I feel like I know you better than ever before, based upon your humility and willing to be vulnerable and share this story with young learners and folks that are practicing. I usually wrap up the episode by saying, if you were sort of to wrap this up in one or two bullets or sentences of what the big takeaway is, what would you say the big takeaway and learning opportunity is from this story that you took away?
Yeah. I think the biggest one is that these stories will never leave you. And I will say this, and this is the part of the story that's the hardest for me to tell, unfortunately, which is years later, I'm at the deli counter at one of the grocery stores here in South Florida. They call it Publix, the shopping center. I'm dressed up in a t-shirt and shorts, and I'm waiting for my turn, to buy some deli meats. And there's a lot of other people around and people walking up and so forth. And I look to my right, behind me, I'll never forget, and I see someone who's looking straight at me. And when someone's looking right at you, you kind of, okay, you're looking at me. Do I
Mm,
know them? Type of thing. And it had been years, but this was the mom. Okay.
mm,
And she looked at me. You know what she did, David? She
mm,
turned around and she storms out of Publix. Okay. When I say that never will never leave me, that will never leave me. Okay. So
Mm.
I know that she knows what happened. She understands very clearly that something could have been done better. Okay. And so, you know, that story is the one that I've never really told this to many people. I've started to open up about it because I recognize that these unfortunate things where someone, and the child ended up dying 36 hours later. Okay.
Mm.
And till today, I will tell you that it's it's because of my miss. I did not give the right medication at the right time to the right child. It just should have been an emergency department medication. And I've never, try to get help for all these issues that I've had.
Yeah.
And but the main thing is that you can't just erase the whiteboard and then come to work the next day. This is what's really led me on the mission that I'm on today. And when I go around the country and I talk about this problem, and someone says to me, "Hey, what you built has helped me treat a child or save a life," I smile a little bit on the inside because it's that's part of the little bit of healing. It's never going to fully heal, but it's a little bit of healing that potentially I can try to heal myself for the pain that I've caused to that family. And
Well,
that's the hard part.
yeah. Well, it's a beautiful story, and I know that you probably have many stories. This one is, wow, I'm going to carry this too. But the thing is, Peter, is that by telling this story and talking about it, um, it just reminds me what an amazing human being you are. Because at the end of the day, HUMED is really about human medicine, and we are all human beings. And what I think is courageous is not only telling the story, but you developed a system wide process and are disseminating a system wide process so these things don't happen. And you talked about the RCA, but in this case, there were multiple system issues that could have been addressed, and if they were addressed, may have prevented this from happening. Despite Steve's efforts and your efforts and the nursing efforts. So, as always, honored to have you and spend time with you. You're an amazing human being, and would love to have you on the show again. So, thank you.
Thank you, David. Thanks for all that you do. I've learned so much from you and how you bring heart to the bedside. And I wish and I hope that many people learn from you and how you do things, and we can
Thank you.
spread that type of love, not just to our patients, but to our colleagues as well. So thanks for having me.
Awesome. Have a great day, everyone. And for those of you who are listening, please, you can listen to us on YouTube, Spotify, wherever you hear your podcasts. And hope everyone has a great day. Thanks. Bye.
Thanks for listening to HUMED with David Spiro, MD. If you like this episode, make sure you're subscribed on Spotify, Apple, or your favorite podcast platform. The video versions are also available on YouTube. Make sure you subscribe and hit the bell there so that you never miss a future episode.